Good evening and welcome to Bollards, Plastics and Glass on ScheinTV. I'm Peter Norton. Dentists and patients deal with the challenges of tooth wear on a daily basis due to a complex interplay between countless patient and technical factors. So it's no wonder that no two patient cases are the same and that there are various ways that any one case could be managed. This evening we are lucky to be joined by three experts who are here to share their knowledge and experience in how they approach tooth wear cases, with specific reference to the use of glass ionomers, composites and ceramics. To be clear, our experts are not here to provide a one-size-fits-all formula on tooth wear management. Rather, they're here to help us refine how we think about the management of tooth wear so that we can synthesise the best plans for our patients. First though, here are some heavily summarised introductions to our guests. Professor Ian Meyers works closely with various universities, dental companies and the ADA, as well as in private dental practice. Dr. Anthony Mack works in private practice with a particular interest, training and expertise in implantology and emerging dental materials and technologies. Dr. Chris Ho is a prosthodontist in private practice with qualifications from and teaching positions with universities in Australia and the UK. All of our experts are well known for their frequent involvement in dental CPD and for developing innovative treatment techniques in their respective fields that help us all to deliver better dentistry to our patients. So each of you has one or two areas of specific interest in dentistry, and that expertise puts you in an excellent position to argue on behalf of plastics, bollards, glass, or all three. So in the context of the clinical cases we'll see shortly. Ian, how would you describe your broad philosophy to approaching a patient with a tooth wear issue?
Yeah, thanks, Peter. Look, as a general practitioner, I'm looking at a range of cases. I have a practice which is a lot of older patients. Quite often my patients don't have vast sums of money to spend, so quite often it's about doing conservative treatments, things to keep the teeth going while they're waiting to do maybe something more complex. But it's all about conserving tooth structure. It's very much about getting the oral environment correct before we go in and restore.
Okay. Well, Anthony, what's your general approach?
Look, I'm in private practice, and I'm very lucky that most of the patients I get to see nowadays are in the sort of the baby boomer era, where they're able to have comprehensive treatment and are willing to have a good mindset and to take their teeth to the later stage in life.
Chris, how would you describe your philosophy?
Well, Peter, I call myself a contemporary prosthodontist. We were joking before with Ian, and many times as prosthodontists, we tend to do a very reductive approach where we prepare teeth. And in cases of tooth wear and those sort of cases, I prefer a more additive approach where we're not reducing tooth structure. We're conserving as much tooth structure as possible. So that's really where my philosophy is.
Well, it sounds like we'll have plenty to talk about and maybe even a healthy level of debate. As our discussion progresses, you can contribute comments and questions via the Henry Schein Facebook page or by taking out your smartphone, opening the browser on your smartphone and going to Schein.tv. In a ScheinTV first, this evening our experts will award thank you gifts for the best questions contributed to the discussion. You can see those gifts on screen now. If you're watching us on Facebook Live via a Facebook page that isn't the Henry Schein Facebook page, welcome, thanks for joining us. You will need to switch to the Henry Schein Facebook page to submit your comments and questions because we won't see your comments and questions if you submit them on any other Facebook page. We'll get to as many questions as time allows. As always, by joining us this evening, you're eligible to claim 1 hour of scientific CPD. We'll let you know at the end of the presentation how to claim your CPD certificate. So we all know that tooth wear is really common. Ian, what is it that the international experts are telling us worldwide about how we should be managing tooth wear?
Yeah, look, the prevalence of tooth wear is probably increasing, but more importantly, I think practitioners are becoming more aware of it. There's certainly more publications out there. I think there's probably some general concepts out there which we can take on board that, tooth wear can create some significant issues and challenges for dentists on how they should manage it. I think we all accept that tooth wear is multifactorial and you need some detailed investigation and diagnosis before you plan any management strategies. But the issue is when to get in and when to restore. Quite often you're looking at it. When is it supervised neglect? When is it that you need to go in and restore? And often it's the patient that's presenting when they think they've got a concern, but they often don't know in the early stages that they've got that issue. But I think the key issue from my perspective is there is no single or best restorative management approach for tooth wear. You need to consider a whole lot of things. I think you need to consider the patient age. You need to consider what their expectations are, diet and lifestyle, lots of other factors, and also what they can afford. But also the practitioner can provide.
You mentioned that often patients won't know that they have an issue. That's, I think, something that we can all relate to. How do you go about convincing someone or demonstrating to someone that there is something going on here?
I think it becomes part of your examination. So a lot of people quickly chart teeth, they'll look at caries, they'll look at periodontal disease, and they might say, oh yeah, there's some wear lesions, but they don't actually chart it. Yeah. I think we've got to sort of realise that it's part of the examination. You need to be aware of it. You need to explain to the patient that things are outside what you'd consider normal for that patient's age group.
Ian, would you think, like in a traditional concept, that wear used to be related with age? And that used to be grouped in that, but I'm seeing in private practice that there are a lot of patients who have wear, but are much, much younger.
Yeah, and I think that's really interesting. I don't do a lot of paediatric patients, but there is certainly an increase in wear in paediatric patients. So you can look at this right from the early ages right through to those that have got very few teeth or some teeth remaining when they're very elderly. And look, I think irrespective of that, when you decide you're going to do some restorations, you need to then decide, okay, well, if I'm going to do this treatment, how long is it going to last and how are we going to look after it? Because at the end of the day, maintenance, I think, is more important than just doing the restorative treatment.
I think the main issue is getting the etiology of tooth wear, because even doing all this restorative treatment, it's not going to last unless you deal with the etiological factors.
Absolutely. Yeah. And getting back to Peter's question, there was a great series of papers that came out in the British Dental Journal back in March of this year, and a series of topics were covered there, and it went through the etiology, the various types of treatment. And I think this is a really good summary there. But the issue that David Bartlett put in his editorial was that, hang on, not all tooth wear necessarily might be progressive, and some of it you might be able to control. So if you're seeing something early, you tell the patients early, and you can tell them that if you modify your diet and lifestyle, we can probably stop this in its tracks, and it may not need restoration.
But at what point do you think that is manageable?
Okay, let me take one of the papers in this article here.
Great.
I'm going to refer to this one. And this is out of Nijmegen, Netherlands University. They talk about the Radboud philosophy. It's one of the universities there. It's not new, it's been around for a while. But what I like about this is you'll see at the top here, it talks about age of the patient and tooth wear. Is it pathological or is it physiological? So you've got to consider, when is that going to be the situation?
So what does it mean, pathological and physiological?
Now there's a good question. I might have to give you the first gift. You want some Fuji bubbles?
Congratulations.
Well, we'll come back to that.
Have you ever?
Maybe presenters are excluded from it, but it's a really good question. So my answer to that one would be is that you, as the examining practitioner, what do you consider to be normal in terms of tooth wear? We all might say, yes, you've got the mamelons on your teeth when they first erupt, and when do they wear off? And when you lose that, is that normal wear to see those disappear? Or do you say, look, the incisal edges look flat, I can see facets on the canines. When does that become something that's not expected? And certainly as a patient ages, you can say, well, that's probably normal physiological changes. But I think it's a really hard one. There is no yes and no, what's pathological or what's physiological.
It's interesting because a lot of dentists talk about wear and bruxism. Yeah. But oftentimes it's not just bruxism, is it? You get a lot of acid erosion, you see this cupping of the dentine.
Absolutely.
That's right.
Very, very common.
Look, I think, from my perspective, that's the big thing. And I spend a lot of time diagnosing. Now, unfortunately, tonight we haven't got the time to go through looking at diagnosis. And we really want to try and talk, in the limited time we've got, more about the management strategy. So, in my practice, I spend a lot of time doing composites. I do a lot of rebuilds of worn dentitions. I'll often use stents. I'll often build up the anteriors. It's one of my philosophies to do the anterior teeth and the posterior teeth. And you can get some good results. But
fantastic composites here.
But
you don't give yourself enough credit.
Yeah. But I don't do your lovely primary, tertiary, and all the anatomy that you put in and putting the stains in the fishes.
This is not required in this case.
So this sort of comes back to me about what's going to be functional.
Yeah.
And it led me to sort of the concept of, you need some certain aspects of the teeth to make them work properly. They're not just quite lumps on the teeth, but they are basically trying to give back what the patient have. And a lot of my patients are just happy to have some teeth back. They're not looking at high-level aesthetics. They're not looking at all the ideal anatomy of the teeth. They just want to be able to function with it. And quite often these ones will then go on to maybe some more complex treatments. This is a younger patient. He's only in his early 20s. But then I've got older patients like this. This is a patient in her 70s. She's a pensioner. She hasn't got a lot of money. She's got a lot of plastic on her teeth. And if you look at this, she's got these amorphously shaped little blobs all over the teeth that over the years have not really got much shape. So this is what I tend to refer to as the bollard. So if people don't know what a bollard is, a bollard is usually some sort of post they have in wharves to tie boats to. It's also referred to in traffic control and to stop people barging into things. But to me, a bollard is this little short stumpy thing that just sort of protects the tooth. So the dental bollard is all about keeping the tooth intact, keeping it there so that something else can be done to it later, or even keeping the bone intact should they need a denture or an implant down the track. So this particular case, my question is, what do you do? I mean, I said to this patient, we'd like to do some complex care. And her response is, but I don't have the funds. I don't want to sit in the chair for that long. And she often says, I'm going to be dead next year anyway, so why bother spending the money?
How old was she?
She was 78, I think, when I started this treatment, or thereabouts. 70, I think about that age, yeah. So I'm actually going to show you a slide of this patient. Yeah, she's 78 when I first did these images here. But I want to show you what happened over the next 10 years and then 4 years after that. And you sort of wonder, what the heck's going on here? Because there's been a heck of a lot of change in this lower right quadrant.
It's got an extra tooth.
Yeah, well, there's a 7, a 6, a 5 and a 3 there. Now she's got a 7, a 6, a 5, a 4 and a 3. So I think, how the heck's that happened? But this is actually the mesial and distal root of the 6 because the thing's eroded away so much. But what's important to take out of here is that the whole time there's been an ongoing erosive component. So it's not really bruxing, it's not attritional wear, it's not an abrasive wear. This is purely erosion, the teeth are dissolving away. If I had to put crowns over these teeth, you could say, well, that will protect them and make them good. But you've got a dry mouth, which you can see with the tongue and the lack of saliva. All these acids, root recession or gum recession exposing the roots, you're going to get caries, you're going to get breakdown of that anyway.
So Ian, can I say that with all the, I would assume that you would have put this patient through a very high level of maintenance and preventive program. Even with that, you're still seeing erosive wear. Yeah. Is that an answer saying that preventative is not the only key in treatment of these patients, or it needs to be in combination with some form of restorative aspect as well?
Well, there goes my second box of Fuji Plus. Fuji Bulk, there's a good question. But look, you're right. Preventive measures can only go so far. You need to get intervention at some point in time. So getting back to that point about physiological versus pathological, there are some patients where the risk factors will always be so great that whatever you do, you're not going to stop it. So I think you need a blend here. Now, look, I'm looking at a patient that didn't want to go into anything too complex. So over this 10 years, she thinks this is great. Those teeth are still functional, but they haven't got any shape. They haven't got any clues on anatomy. They haven't even got contact points, but they're very functional for that particular patient. And at this stage, how much do you want to sit in the chair? I mean, this patient at age 92, she's got, a lot of almost nothing left. But you do have to be careful. You have to watch these people because, you can get periapical lesions. You've got to make sure that you're monitoring what goes on. There's no way you can leave these people and just forget about them. You've got to watch what happens.
And that's the point there. I think that even though there is a stronger, higher percentage of patients that even with physiological wear, they need restorative treatment.
So, the question would be, should I have taken out all these teeth and put implants in? There's some complex issues around this, and that's a very invasive way. But this lady is exceptionally happy that she's got her own teeth. Not many of them left, not much of them left, but she's so thankful and grateful that now, she's actually a couple of years older now. She's 94. She's in a nursing home. Yeah. She's happy as Larry.
So, Ian, these bollards, what are they? I mean, you just talked about these. Are they just GIC build-ups? Is that what you're using?
Look, I use a lot of GIC for these. Sometimes I'll put some glass on them, so some composite over the top of that as well. But realistically, it's just something that's going to adhere to the remaining tooth structure. We hear all about our lovely adhesives that bond to enamel. I don't ever see any enamel in these older patients. So you're down to dentine.
And these sort of patients, I mean, they've got a lot of erosion. Do things bond so well to these types of teeth?
Yeah, and again, that gets back to the issue of the remineralisation and getting some strategies in about using things like the dry mouth gel, the tooth mousse, getting that remineralisation happening so that you've got something strong to bond to, otherwise the whole thing's going to fall.
So what would you recommend? Would you recommend them go on a tooth mousse for a few weeks before they come in to do restorative treatment?
Yeah, look, what I often say in my toothwear courses is I talk about the 4 to 6 week period where you got to look at their diet, lifestyle, increase the hydration, then you look at getting onto putting the remineralisation agents into it. So whether that's high fluoride toothpaste, tooth mousse, with your dry mouth patients, you really have to have some calcium phosphate. So you've got to give them something else.
So Ian, is there any research to show how long you should put these patients into this preventive program before you assess?
However, there is data which shows after 2 weeks you can see some surface remineralisation of enamel. Theoretically, it's going to be happening in dentine as well, but there's not a huge amount of data on that. But certainly, you do see an improvement in the salivary parameters. You see some changes in the surface texture. You know when something's going to be better to bond to.
But there's a lot of patient factors there. How do we know that patient's just doing for 2 weeks just because you told him to? Are they going to be able to maintain that for long term?
Look, that's the same as anything. And the question is, how are you going to get compliance out of the actual patient? And I think you've got to get them buy-in that it's their responsibility to look after it as well.
Okay.
Well, thanks for your questions. If you've just joined us, you can contribute comments and questions via the Henry Schein Facebook page or by taking out your smartphone, opening the browser on your smartphone and going to ScheinTV. And this evening, remember, our experts are awarding thank you gifts to their favourite questions. If you're watching us on Facebook Live via a Facebook page that isn't the Henry Schein Facebook page, you'll need to switch to the Henry Schein Facebook page to submit your comments and questions. Also, if you're watching us on Facebook and you're enjoying the show, feel free to like and share. So, Ian, if we go back to the radiograph there, you had some interesting comments when we were chatting before about the periapical status of those teeth. What can you tell us?
Look, literature tells us that in older patients, most of these are going to be asymptomatic, and over 85% of them are probably going to be either granulomas, sometimes cystic, but obviously you've got to look out for draining sinuses, you've got to look out for swellings. I've got an interesting thing I'd point out here, probably on this lower root stump down here. I mean, to be honest, you'd say that that's got a periapical area, but if I look at it more closely, that might be the tooth exfoliating and I'm getting bone growing into the socket. I mean, it's an interesting concept down here. I mean, certainly some other areas you might say there's definite periapical lesions, but that's where the bone height or the root height used to be, and now it's sort of resorbed in and you've got some bone looks like it's going in there. So are periapical lesions as sinister as we think? And to me, it's a case of you need to do the clinical exam. You need to review them fairly frequently. You can't just say, I'll see you in 6 or 12 months' time. Sometimes they need 3-monthly reviews.
In looking at this X-ray, and you're saying that she's in a nursing home now, but before she gets in there, is it something that we should be wary of and maybe consider some?
Yeah. One of the big things that I'm a big fan of is when people get into that 70 to 80 year age group, you do an overall review.
Yeah.
And one of the things that we've sort of looked at now in the concept of the silver wave is to bring in this concept of reviewing patients when they get to that stage to pre-prepare them for that age. Just as you might do an APG for someone who's late teens, looking at wisdom teeth, looking at all sorts of things, it might be a good chance to go back, look for pathologies in the older patients and prepare them for their advancing years. What I call the newly old need to be looked at before they become the aging old.
And look, that's exactly what I've been doing in my private practice as well. And people in that sort of demographic, I have to now start to think about this type of treatment, that if we're going to do some comprehensive treatment, are we going to do it early on, or do we wait until then maybe not as capable to have this type of treatment?
Yeah, that's always a difficult question. And I think that you've got to talk to your patients individually and work that one out. I mean, I know that a lot of patients don't want a lot of invasive treatment, and certainly as they get older, they're less concerned about the aesthetics, but they still want function. And they still want to be able to eat. They don't want to put their teeth in the glass next to the bed. That's the big thing I get. They want to be able to smile at their grandkids, give them a hug, not smell strange and not take their teeth out. Yeah. And that's an interesting thing. And I think that people aren't accepting dentures like they used to.
Oh, I definitely agree. So I guess maybe I will go through. I should talk about some of my cases.
Before then, though, we've had a question aimed at Chris. Chris, you've been discussing things with 3D scanners lately, intraoral scanners. Do you see that there's any role for using 3D scanning technology to monitor tooth wear over time?
Yeah, that's an interesting question. So in the past, we used to use like study models, we'd use like templates, we'd use tooth wear indexes to monitor tooth wear. But recently, 3Shape has actually released patient monitoring software. So you can actually monitor patients over time by using a scan of a patient and comparing it. And in the actual software will show you how much change there has been over time. So I think it'd be very useful for these types of patients. I think very interesting concepts.
And I think with more time and more data, I think collectively with this type of technology, we'll be able to get more information to create consensus at what point do we need to start looking into treatment, and how fast is the wear rate, and what's the average of what we call physiological wear.
And I think that's an important one, because in the past that's been very much an academic approach. It's good to write about it, but how do you turn that into this translational research to say, here's some clinical guidelines around it? Because I think that'd be great.
It's quite interesting what you said. I mean, it's erosion and wear tends to cycle. It's not just a progressive thing, but sometimes people go through very fast stages of erosion and then slows down again.
Absolutely.
So.
And now a question for you, Ian. What is a physiological process that's driving the over-eruption?
Again, it's a bit like the Dale concept, isn't it? And I know we'll probably talk about this later on, but if your teeth aren't in contact, they physiologically want to come into contact. So I don't know, there used to be suggestions that it was age limited, it would only happen with maxillary teeth where the bone wasn't as dense, but I certainly see over-eruption in a range of different teeth. So it's basically an orthodontic movement. The teeth want to be in contact to pose with something. And all of those little bollards I showed you before, they were all in contact. Now you could say it was loss of vertical dimension, you could say it was change in the alveolar bone growing up, but I think sometimes
combination of each,
a bit of everything. So I've got no evidence or proof, but I saw that X-ray and thought, that's an interesting one. Maybe there is physiological eruption simply so the teeth are back in contact.
Well, Anthony, your cases are next. What can you tell us?
Oh, look, I'm going to start off with a little article like Ian did. And this was an article from last year. It was actually the European Consensus Statement on the Management Guidelines. And it's more just a very simple summary. And basically, just to summarize, it talks about that we need to assess the rationale or the reasoning behind this wear. And I guess this is something that is probably a very big scope that we can't cover in today. But what the statement also says is that once you've decided that treatment should be carried out, whether it is be a functional or an aesthetic concern or patient concerns, then we should carry out what we call a least or minimally invasive sort of technique using, like Chris said, additive techniques, whether with bollards or with composites or with ceramics. And the end goal is to create a functional restoration for the patient, but using using a technique where we can have the least amount of destruction of tooth structure. And so I'm going to start off with a very different case to what Ian has talked about. I'm going to talk a much younger patient, and this is Aaron. And we started this case a few years ago, about 3 years ago, and he first was referred to me by another dentist in my practice, and he was complaining that his teeth were thinning, and that he was unhappy with the graying show-through of it. And so at that time, he was 34 years of age. He was concerned about the aesthetic changes that was occurring in his central incisors. And basically we went through the hygiene program, we saliva tested, and finding a little bit more history, we found that, look, as a young adult, he was partying a lot. He didn't really look after himself very much. And then, so when I took a series of records, you could see that there is definitely some early signs of damage. And I would say this is not physiological for a 34-year-old. I hope you can agree with me on that one.
I definitely agree with that one.
So, and when I look closely, especially in the upper palatal of the upper anteriors, you can see that all the enamel has been completely eroded and eroded through, to the point where one of the centrals, the 2-1, was almost down to the pulp. At this point in time, I think that the diagnosis and the preventive is important. But regardless of what kind of preventive measure or continuation of prevention we put Aaron into, we still need a restorative aspect. At 34 years of age, how can we just say that we do no treatment on this and expect that he's going to keep his teeth for until he's 90? So in this case, I wanted to be conservative. I wanted to do as little preparation as possible. Obviously, being young and he's just had a young baby, cost was an issue, so we couldn't go into really extensive treatment sort of modalities. And so I said, okay, what would be the best treatment that I could provide him and manage this sort of problem that he has? So we went through the etiology. We know that he's got a problem. We put him through this all the high fluoride toothpaste, all the regular hygienes, controlling the diet. He used to drink a lot of soft drinks, so we went through the dietary things. We put him on tooth mousse, and then we decided that we definitely need to have treatment. In this sort of scenario, where the incisal edge needed to be treated, my sort of goal in this sense was trying to not mix up too many different materials in that areas, especially when I'm trying to finish a margin on the labial surface in that case. So if I went with, let's say, a porcelain or a palatal veneer in that case, I would have had porcelain, I would have had resin as this luting cement, and I would have enamel finishing on my labial surface. And I know that with time, that's just going to stain. It's going to be, initially it might be aesthetically pleasing, but after a period of time, it probably won't. So in this case, I decided to do composites, and I did it in an indirect sort of way. So what I did was I did a digital mock-up, as you just saw in the models before, and I wanted to do an additive technique, a no prep technique or minimum prep technique. So the way I did this was that we got a digital mock-up after an intraoral scan, and we used a clear silicone, and this is a clear silicone that I really like, and it should be coming into the country soon, and it's super clear, and that's why I like this sort of material. We take a mold of our mock-up, and I basically built up these composite palatal veneers in a semi-direct fashion. So I actually don't bond them in. And I find that the reason why I do this is that if I do them directly or at once, I find that I have a lot of excess and I have a lot of flash, especially when we did a mock-up in this sort of sense.
So you use a digital mock-up, so I'm assuming that's what I'd call a wax-up.
Yep.
So, I have to go to the technician or wax it up myself, but you can digitally create this, can you?
Oh yes, with all the softwares that we have available, the intraoral scanning, the traditional lab software can mock these teeth up. And look, the software's been around for a long time, but I think it's the printing technology or the ease of assessing these mocked up models by using just simple printers has opened up this sort of treatment modality. Would you agree, Chris?
I agree. I think digital wax-ups has changed prosthodontics immensely, because to do a digital wax-up takes much less time than doing a traditional wax-up. A technician would spend the whole day doing a full mouth. A digital wax-up probably could be done less than an hour. So much more better use of time.
On that note, Chris, we have had a question for you to please repeat the tooth wear monitoring software you were talking about.
It's actually from 3Shape, and it hasn't been launched yet. I think it's been launching. It's still in the beta version, but I think it's going to be launched in maybe next quarter. I'm not quite sure about that, but very, very soon.
We'll sit tight.
So it's called patient monitoring. Patient monitoring. Yeah.
Okay, great.
Okay. So in this scenario, we built up these palatal veneers separately, and we did it over 2 occasions. We did alternate teeth, and then we trimmed them up, and we basically bonded them back into the mouth.
And they're in composite.
Sorry, they're in composite, yeah. And once we've bonded these back in the mouth, we did a little cutback, and we just layered some anterior composite over it. In this way, we were able to have just 2 materials, composite and tooth enamel, and we were able to get an aesthetic sort of outcome. So you can see here the palatal surfaces are now built up, and you could see that we've provided him good function and prevented him to have, minimize the risk of having more wear. And we did this conservatively in a simple approach and systematically, and I think doing it in a semi-direct way was actually a very, very good idea.
My concern there would be that if natural tooth structure struggled to weather the storm of his function, parafunction, how do you expect your composites will hold up?
Look, I think in terms of material-wise, composite actually stands up very well, because if you look at the options we have today, we have GIC, we have composite, which probably will wear very similar to tooth compared to like porcelain. Porcelain will probably wear the opposing dentition and actually make it worse. We have hybrid materials like indirect composites, which seem to work exceptionally well, and there's studies to show that seems to be the best material out there. And really, the zirconia is probably will have difficulty bonding to that and getting aesthetics to that. And so those are the sort of materials that we have to play with. So in my practice, I would definitely recommend a composite root, because you can repair this. So you can reactivate it. If you get wear, we can improve on it. So we can add it back on. Whereas the other materials, for example, like ceramics, you can't.
And which composite have you used in this case?
This one we would use Genial, and we used Genial. This was a few years ago. We used the GC composite, and we just used a simple shade, and we stained it up with some stain opti-glaze. And,
so I'm assuming you mean Genial anterior?
Anterior, yeah.
Not the Genial universal?
No, Genial anterior paste composite.
Okay.
And then we just used a single shade, and we just stained it up with some opti-glaze. And we laid it front with an enamel composite.
So 2 comments. Going back to Peter's comment, I think, it's not just about attritional wear. You've got some erosion happening there. So I think composite's going to be more resistant to erosion. Obviously, it's not going to dissolve. But what you have to watch is the margins if you haven't got rid of the erosion. But it also brings up the issue. You've used direct and sort of indirect composite. And often people say to me, how do you stick composite that's indirect and new composite? Will they stick to each other? Is it an issue?
Look, I think this is freshly cured composite. So we did it in a 1 appointment. So I don't think there's an issue with bonding composite to composite when it's fresh, because there's always uncured monomers there. So it's where you have old composite where we've been in the mouth for a long time. That's where you might have a reduced bond strength between composite and composite.
Certainly a great result, Anthony. Very conservative.
Yeah. So
lovely.
But you did nothing on the posteriors?
Posteriors, we did nothing on the occlusal on the uppers, because there was no signs of wear. On the lowers, there was definitely signs of wear as well. So we had to open up the bite, and we used some minimal preparation occlusal overlays.
You used some stain in those fishes, have you?
No, those were actually done with ceramics. So they were done with lithium silicate, and we were able to bond those in, and so we got a good functional
Why do
result.
people put caries back in these teeth? I've always asked this question. These stains, what's the point of putting the caries back in?
It's a vicious selling for later on.
Oh, okay. I always wonder why you put these stains back in. It looks great from the dental point of view, but do patients really like that?
Oh, well, look, each to their own. I mean, I've seen lots of stainings around.
Fine, that's
And
all
if
right.
it's on the
I won't
palatable,
argue.
I guess we're just the only people who will see it anyway. We have a question as well. Given that patient factors play such a role in determining success, particularly of direct build-ups, what strategies do you guys use to sort of meet patient expectations?
Well, now there's a really
That's
good
a long
question.
question.
Someone can have a prize for that.
I think so. That's
That's a gift somewhere for that.
Is that for a composite restoration?
Congratulations, Chris. The suggestion here is direct build-up, so I would be thinking
composite. Okay, we'll definitely deserve a prize. Can we note that down?
a gift will go out for that.
Look, I think I would do the same type of routine, because I think whether regardless you use composite or GIC or ceramics, I mean, even with ceramics there is a part where you'll be bonding it to. So in terms of the preparation for the patient to have these type of restoration, we'll still do the same, making sure that they're regular with their hygiene, making sure they're stable for a period of time, where checking on their habits, where if there is any sort of dietary things we can see, but definitely fluoride, tooth mousse, and regular recalls, and actually just monitoring that their oral hygiene is good, whether the plaque, and then determine from there whether they're ready to start treatment.
Yeah, I think you've got to have realistic expectations as well. I mean, we haven't given the patients the tooth wear. It's part of their diet and lifestyle. And so they've got to accept some responsibility around that. And so you've got to talk to them about what they're going to achieve, what they hope to achieve, and the limitations or whatever we decide. And I think that's got to be clearly spelled out.
And I think if you do no harm, you don't remove the tooth structure, there's a low risk of pulpal involvement. You're helping the patient, I think, in this sort of aspect. Does that answer the question?
I think it does. While we have a pause, another question. How do you manage ageing patients who have had a lot of complex treatment, for example, crowns, bridges and implants, that's now breaking down, particularly with respect to root caries and caries at the margins?
Yeah, that's where I refer to, Chris.
Good. So I guess...
Because honestly, bonding to ceramic, as much as we have beautiful silane coupling agents, as much as you've got great stuff, composite and glass elements just don't work long term. And if you've lost vertical dimension, if you've got changes in that occlusion, I don't think you can do it with the elderly patients easily. You can do some compromises, but if you're going for that across the board, I think you're really looking at some specialist prosthodontic work.
Well, this viewer was talking from more of a public health dentistry perspective, so I suspect.
So again, there are ways you can build up teeth, and you've got to decide when you change the vertical dimension, what are you going to keep as stable. Obviously things like crowns and implants, basically they're not going to change, so they form the basis of where you do your new dimensional build-ups too. And I think probably from that perspective, I use a lot of glass ionomer in those ones.
But isn't it also important to maybe assess them before they get to that later generation? Like what you said before, assess them when they're 16, 17. We can get to them early.
Unfortunately, some people don't attend for maybe 10 or 15 years, and all of a sudden come out of the blue like this. And I get a lot of these patients, and having worked in the public sector in the past, you get someone who's come out of the blue that hasn't seen a dentist for 20 years, and you go, oh my goodness.
But in those cases, I think in that age group where they're quite old and they've had a lot of work done, it's not so much the actual decision on what is the best for them, it's what they can manage in the chair as well. They may not be able to manage complex treatment. Their medical history may not allow them to have dental implants. Those cases where we might have to sort of what we call bollards and patch them up, and hopefully that it lasts them for a long term, I think.
Yeah, and the other philosophy that we should never forget is the short dental arch concept.
Absolutely.
For some of these elderly patients, they can't afford to have comprehensive rehabilitation. So to maintain 10 opposing teeth, to give them function, to give them aesthetics, I think is a very, very important key to managing these elderly patients.
And I'm going to go one step further and say that sometimes it might be that a full upper denture will work quite well. Yeah. I'm not going to say the same about a lower, but certainly you can get some good results. But again, that's patient by patient, individualised treatment. It's not across the board as a simple solution.
Okay. Another question, what are the things you would tell patients not to do after these restorations? Presumably, Anthony's yours.
Look, I mean, the good thing about composite is that it should allow them to do everything that they can in terms of dietary and chewing, because worst case scenario, if they do chip one of these composite restorations, we can repair them. So this is maybe different compared to if we were using a ceramic restoration. So in our practice, we would definitely, obviously, all these patients where we restore these kind of types of restoration, we put them into a night splint or occlusal splint, and we obviously would like to see them regularly, but we don't stop them from chewing things. We obviously tell them to be mindful of hard things like hard cookies and nuts and things like that. But from a chewing or dietary sort of management point of view, we let them eat whatever they want.
And Ian, earlier today in our quiet discussion, you were saying that you've had some patients run into troubles with turmeric.
Yeah, well, it's one of the greatest staining things around. If you want to ruin your composites, get people to go home and have a curry after you've done them. Particularly if it's got a lot of turmeric in it. It's far better than tea and coffee. Turmeric's one of those wonderful things, and I haven't quite got into the turmeric lattes yet, but apparently they're fashionable now. But I certainly believe that if you're looking at some severe yellow staining on composites, you're not sure why it's there. A big issue with that is some of the spices that we use in turmeric. It's definitely one of those. It usually polishes off pretty well, or using air abrasion or some sort of cleaning process. It comes off pretty easily, it's superficial, but you'll certainly notice if you haven't done full polishing of your restorations and there's some oxygen inhibited layers there, it absorbs it like a sponge, and you've literally got to go back and polish it all back. Otherwise your composites are pretty terrible.
Well, Chris, do you find that composites are more vulnerable to stain in the early days for that reason? I mean, do they progressively become less risky for stain, or is that a fairly lifelong thing?
I think any composite can stain because it's a type of resin. But like Ian said, if you're removing the oxygen inhibitor layer by giving it a really good polish, you'll get less stain. So the better the polish, the less staining that you're going to get. But like Ian said, also you're going to get the turmeric. It can stain those.
It'll even stain some.
But also, his main thing is where we finish the margins of these composites. If we're finishing them in enamel, and they're bonded well, you find that they're less likely to have this stain. I mean, the marginal stain is probably the worst.
Well, that's more micro leakage, isn't it?
Yeah.
So that's
So
more
if you
like
haven't
an adhesive.
bonded properly,
Well, before we move on, Dr. Mack, in the case of Aaron, did you raise the OVD? Otherwise, how did you have space for the composites?
I did. In those cases where I balanced, I opened the bite up. And look, opening the bite up is a discussion for another sort of topic. But in those cases, I will put them into a deprogrammer, get them into a stable sort of opened video, and then I tried to then open them up to that where I would enough space for me to restore those restoration anteriorly, because that's my concern, and then I'll build up to the posteriorly to that video. There's a lot of talk about sort of dial techniques and things like that. I think in that case there was definitely lower erosive wear, and because of that I decided to restore the lowers, and also I wanted to balance the occlusal scheme as well. There was definitely a deep curve of spay, and the lower had intruded into the palate during that aspect, and so hence that's why we opened the bite up.
Yeah, I mean, I'd love to make the comment that people get scared away by opening the vertical dimension, but if you've got tooth wear case, you can't add to it without opening the vertical dimension. It's absolutely
What's the
impossible.
alternative? The alternative is you have to prepare the teeth.
Yeah, I've seen so many people build them up and then grind them all back down until it feels comfortable. I've taken off everything they just put on. So
and people forget about orthodontics. What they do when they brack them up, they torque the tooth. When they torque the tooth, they're uprighting it, which means they're opening up the bite.
I mean, I've done a lot of vertical opening over the years for lots of patients, and certainly I very rarely get any muscle or joint issues. I think if they're pre-existing, you need to be aware of that, but certainly people seem to tolerate it quite well.
Most patients adapt within 2 weeks' time.
Yeah.
And it's quite safe to raise vertical by up to 5 millimeters. Abduo in 2012 has shown in his review that opening 5 millimeters is quite a safe and predictable procedure.
Yeah, you're very conservative. I'll go up to about 9 or 10 sometimes.
9 or 10. That's like putting high heels on them.
Yeah, but it's surprising. If you don't see them for a couple of weeks, they get used to it.
Another question. Often some patients present with wear after they've had some form of previous intervention to protect heavily broken down teeth using indirect restorations. How do you manage these patients that may now require an increased VDO? How do you communicate this to the patient, especially if they've spent already a bunch of money on posterior indirect restorations that now require removal? Chris,
just clarify the question. So basically, someone's had a lot of indirect restorations
in the past,
and now they've got a collapsed video or wear on those restorations. How do you communicate to them that they need to have another round of dentistry? Is that what?
That's right. Or I mean, an option there would be that someone's come in with wear and have had just piecemeal crowns placed here and there, and how would you? Well, Chris, how would you manage that?
So patients with previous dentistry that's been basically having to be redone, I guess nothing lasts forever. We'd like to think that our dentistry is going to last forever. It doesn't. Their teeth, patients' own teeth hasn't lasted. So whatever we put in patients' mouth, also experience some deterioration, some wear. So maybe for those sorts of patients, you might be thinking about metal, gold restoration. There's nothing wrong with gold onlays, crowns, etc. for maybe some posterior teeth. So I know we like to have very beautiful aesthetic restorations, but sometimes we still should go back to the old conventional gold type of crowns restorations. But approaching those patients, it can be difficult. It can be a very difficult discussion, with the patients, because you've done one round of dentistry and you have to do it again, basically. I guess our dentistry, the patient has to take some blame, some part. We are doing the best we can for our patient with the materials that we have, but as I mentioned, people can parafunction. They have all sorts of attack to the teeth, chemical attack. These things can break down. And you have to explain to the patient, what we're doing for the patient is to the best of the materials that we have. Patient's own teeth hasn't lasted them, So I think people do need to understand that as well.
I think it's important to discuss and advise the patients that this is the problem that they have, and let them make the decision whether they want to go ahead with treatment or not. I mean, we can suggest all these things that they can have another round of them, but most of them say, look, this is not what I'm not ready for this yet. And I think it's one of those things, is not to drive that patient away because that they can't afford or they don't want to do the treatment just yet.
I think, as Ian mentioned, patients need to take responsibility for their own teeth as well. And they, I think people like to blame the dentistry, but oftentimes it's the parafunction, it's the acid erosion. There's a lot of other factors that cause breakdown, and particularly I think gastric reflux, extrinsic sort of dietary sort of juices, soft drinks, xerostomia, all these different factors are affecting patients' teeth.
Yeah, but it's fair to say, Chris, that the general rule is if you can have like versus like, you're going to have less breakdown. So if you're going to have gold versus gold in the occlusion and porcelain versus porcelain, because I see a lot of people who've got a zirconia crown here against natural tooth and gold against something, and you can see those wearing so poorly against each other. But it's hard if you're not looking at and you're doing things piecemeal. You end up with this mix and match.
But it is hard in general practice. In general practice, you often see treating people with emergency, they break a tooth, you fix that one tooth. You're not approaching as a comprehensive. And it can be difficult to approach that with a patient.
Yeah. And just getting a patient to agree to one crown sometimes for a tooth that's desperately in need can be hard enough without saying, well, let's just make you shiny and new. We do have more clinical cases to discuss, but we're going to take a short break to hear a message from Professor Laurie Walsh about the upcoming Quintessence Symposium. We'll see you soon.
Hi, I'm Laurie Walsh, and it's my honour to serve as the chairman of the 10th International Quintessence Symposium on Periodontics and Restorative Dentistry. This great meeting will be held this year in Sydney at the Hilton Hotel from October 11th to the 14th. This landmark biennial event brings high-profile international speakers to Australia, and it showcases excellent Australian and New Zealand presenters. The theme for 2018 is New Frontiers of Aesthetic Excellence, successfully integrating the best of traditional and digital dentistry. This year we're including an additional pre-symposium day before the main meeting. Now we've done this rather than running concurrent streams in the main meeting. That way you're not torn between what sessions to attend. As in past years, we've aligned the program to the key topics in restorative dentistry, periodontology and implant dentistry. Across the 3 days of the event, both the hard tissue and the soft tissue aspects of clinical treatment will be addressed in an integrated manner. The 2018 program includes a wide range of workshops, both hands-on, theory and blends of both. And these provide that more intensive and intimate exposure to the topics of key interest. And of course, the chance to get up close and personal with the presenters. I really look forward to seeing you in Sydney in October.
Welcome back. If you've just joined us, you can contribute comments and questions via the Henry Schein Facebook page, or by taking out your smartphone, opening the browser on your smartphone and going to Schein.tv. Remember, this evening our experts are awarding thank you gifts to their favourite questions. If you're watching us on Facebook Live via a Facebook page that isn't the Henry Schein Facebook page, you'll need to switch to the Henry Schein Facebook page to submit your comments and questions. Well, Anthony, you want to tell us about Effie now?
Okay, well, I'm going to go through very quickly a second case, quite an interesting case. Following on what we've discussed with using resins. Effie was a relatively young patient who came in. She was 40 years of age when she complained of intermittent pain on chewing on upper and lower on her back teeth. Previously, she had a very high stress job. And she just presented for as a general checkup, obviously feeling that something was happening. And so I had a look at her teeth, and I could automatically straight away see, you can see the type of wear that's occurring. And for someone at her age, I definitely would not say that's physiological. And then if you look at her upper teeth, she actually had some cracks on her upper molars, and she was getting some symptoms or positive symptoms to the frac finder. So we needed to go through some treatment, and she was pro to having some treatment. So the best way we wanted to do it was, and costs, we didn't want to drive the cost too high. So we knew that we needed some crowns on the upper sixes because of the cracks. But on the lowers, I wanted to find a simple way to restore these for her, so I can get her through a transitional period. Eventually, down the track, maybe 10 years down the track, she may need some more treatment, or progressively, she may be able to afford some more indirect restorations down the track. But in this case, I just used one of these new injectable composite restorations. And I followed the same protocol as did for Aaron, and I basically was able to carry out very simple composite restorations for her just to get her through. I stressed to her that these restorations may not last her for many, many years, but it is something that to stop the damage that's occurring and prevent her from getting more damage, I guess, and also putting her into a position where hopefully that if there was damage, it was only going to damage the restorative material. And we've known that some of these new injectable, this one I use is from GC, it's called Genial Universal Injectable. They're actually the strongest composite that they have out there. This is newest technology.
I was very surprised.
The wear properties of this is amazing.
But it doesn't make sense, because everyone knows that flowables are weaker because,
I think
how does this work?
I think it's the particle size that they're using nanoparticles, and they're better silinations through them.
Absolutely.
And also the way they silinate, that they're dispersing it very evenly, is creating a really good composite.
That was a trick question. I was just seeing if you knew.
Now, just to be clear, what you're talking about here isn't Genial Universal Flow. It's a new product called Injectable.
Injectable. So basically, it's like a flowable composite, but it's got a consistency between a paste and a flowable. So it's much thicker, and you can test it by that. When you inject it, it doesn't move. It doesn't slump. But you can move the composite around if you drag a probe through there, and hence in this case it was and because of the physical properties, it's the strongest of the composites that they have in the whole range, and they're stronger than paste form, Chris, we were discussing this morning.
What about the shrinkage? Normally flowables have a higher shrinkage. Is this one? What sort of shrinkage do you know?
It's comparable with all the other flows. A very low shrinkage rate, and I think with the shrinkage rate is in flowables, I find is less because of the way that the vitrification of the setting process. They don't snap set like compared to a conventional composite. So I don't feel there's any issues with C factor stress and things like that.
I think polymerization shrinkage is a thing of the past, I hate to say. It's now shrinkage stress is what we're talking about, and what stresses are being put at the margins, and the way that these are used, particularly with some of these build-ups, it's not going to put stress at the margins. I mean, C factor is an important aspect, and a lot of literature and a lot of information about it, but I really think that we've moved beyond that now.
Yeah. Okay. Now, and Ian, I know you do a lot of these cases, and you teach a lot of these cases, and I did this in a very modern way, and I want to share with people that you can do it in a more of an analog way. In this approach, I used the same sort of technique where I used a digital approach, but the really good thing about this type of digital dentistry is that I actually was able, very simply, I asked my technician to just mock up every second tooth. So you can see the model on your left here. I've got the 4 and the 6s mocked up. And on the right, I have every single tooth mocked up. And I can only do that very easily with a digital workflow. And then I printed these models and I created the stent. And the reason why I want to do that was that I can do every second tooth, and I can clean up the interproximal areas so that when I'm injecting them, they're not actually joined together. And so that's what I find was really helped me in this case, where we're able to get a really excellent result. If you had to do it in an adult way, you would have to try to get a really good technician to mock it up one tooth first, take the stent, then add the other tooth, and then take the other stent. So it's not impossible. So, but I just find with this type of workflow where our practice is 99% digital now, it seems to work very, very well.
They're making me feel like a dinosaur here, Anthony.
Well, look,
great.
you know.
I'll have to invest in this digital technology.
Well, I'm happy to share with you if you actually get one.
Yeah, absolutely.
So, if you look at Effie now, I'll very quickly go through it where we took out all the old composites where they were patched up in those sort of craters that Chris talked about before. And I basically put this clear silicone stent in and I injected this genial universal injectable in. And you could see that I used an alternate teeth technique. So now you can see that I finished the 4s and the 6s first. I did a very simple cleanup. And then I put the second stent in. And then I injected and I finished the case this way. Okay. And by doing that, I was able to maintain contacts. I was able to maintain all the, so I can clean and minimize the flash that's around. And basically we got a good result for Effie. And you can see the communion effect of this composite. There's no preparation for this tooth, just micro etch and etch. And we got this is using a single shade as well.
So I can understand how doing the interproximal cleanup is easier for the first round of alternate teeth that are restored. How is it easier for the second round of teeth?
Well, remember, you've followed the same mock-up there, so you really finished the restoration. So when you do the second restoration, you only have to clean up those other ones. The main thing is that it doesn't get too much into an embrasure, because if you did an alternate teeth mock-up where it was a full one, it would just flow right into the space of the tooth that you mocked up.
I think you're also using some Teflon tape to isolate as well.
Yep.
So that's how he's avoiding the flash going everywhere.
And bonding teeth together.
Bonding
so
teeth
you
together.
can just template over that.
Yes.
Teflon tape.
Yeah, definitely. So I mean, that was the finished result, and I think I think I'll pass that on to Chris now.
Before we do that, we have had a question for you, Anthony. For the cracked teeth, would you feel that a composite onlay is sufficient protection?
Look, I think there's a balance there. Look, we have to weigh it up. If I use a hybrid sort of overlay, then it probably will marry up with my lower composite well in terms of wear characteristics. If I have to treat the symptoms, I would be a bit more cautious using a hybrid, because there is still some force absorbing or movement or stress on those composites, and hence the patient may still potentially get some symptoms. If I was treating the symptoms, I probably would go with like a ceramic, like a lithium disilicate, like a Lissi press, because I know that treating the symptoms will be my priority. And then if I get some wear on the composite, I'm happy to add to those composites. Because remember, the adding to the composite is not a problem.
Another question related to your case, how do you feel about things like the one-visit crown or, for example, the Edelweiss OVD restorations?
Yeah, look, I don't have much experience in that sense. And for me, in my practice, I don't see where there's a rationale for me to use that.
Come on,
But
I use both of those.
But Ian has got some experience. I'm not sure if Chris has. I mean, you can bring, Ian.
I won't go into a great big discussion about it, but I think there is a place for the prefabricated occlusal veneers, either with the composite underneath them or without.
But in a multiple teeth, where you increase in bite, do you think it'll save you time doing this technique where literally just injecting, and I've got the conclusion maintained, versus you hand pulling the composite?
Look, it certainly won't save you time. It might save visits. I mean, I get a lot of patients that travel some distance that only want to come to one visit, so they're not doing multiple visits. So I suppose in some cases it's useful. It certainly is complex, and it takes you a lot longer in one visit to do. So I think it's probably not time saving in that respect.
Yeah, I mean, it's very hard to control the occlusion with this type of
Yeah, but see, I think occlusion's overrated in some ways.
Oh,
because,
that's a big call. That's a big call.
When you talk about composites, you can adjust it. I knew I'd stir up the real
I think the verdict is still out with these type of restorations. I think I would like to see some sort of further time with these, how they perform and what's happening with them. But I definitely think that using a digital workflow, it makes things a lot easier.
Okay. Do we think that question's eligible for a gift?
gift.
Okay, great. Well, congratulations. Okay, so all right. Well, let's take over to Chris then.
Okay. So my case is on another sort of tooth wear case. As a case I carried out approximately 9 years ago, and It's a case I really, I think it changed my whole philosophy. As a prosthodontist, oftentimes we do a lot of reductive approach where we prepare teeth. And in cases of tooth wear, it really didn't make sense for me to actually prepare teeth. I'd sit there, and carry out a crown preparation. It didn't make sense to actually prepare those teeth. And I think we all agree that conserving tooth structure is really paramount to better health for a patient. So our case here is a 41-year-old patient who had a history of bulimia nervosa, and she also had some parafunction and sleep bruxism. She'd been to multiple practitioners already, as we often see, and she was referred in for an assessment. And we look at the patient like this and we think, how are we going to restore this patient? What can we do? But the first thing that we need to look at is really what are the problems? And we have to identify the problems that the patient has. And the problem list for this patient is that she has poor aesthetics. We can see that. That's really why I think a lot of patients come to see us. A lot of these tooth wear cases, we can talk to the patients about tooth wear, but really when people come to us, they're often concerned about aesthetics. Probably secondary, maybe a sensitivity issue. So in this patient, we have poor aesthetics, we have chipping of the teeth, some denting or hypersensitivity, reduced vertical dimension, and obviously minimal tooth height. So we need to also identify a diagnosis. So the diagnosis was that she has tooth wear due to acid erosion. And you can tell it's acid erosion because you can see the typical dentine cupping. I often get patients come in and they'll tell me, my dentist tells me I've been grinding my teeth, my previous dentist, tells me I'm grinding my teeth. But it's typical to see the dentine cupping, the typical acid that you see there. So this patient, what are my concerns? What is a traditional approach, a conventional approach, is to prepare the teeth, for crowns. We're concerned about preparing to the teeth. There's obviously a biological cost of preparing the teeth. Oftentimes, 6 to 10% of teeth end up having endodontics after you prepare a tooth. So in this patient, we have a concern that if we prepare the teeth, maybe we're going to have a biological effect on this patient. We also have minimal preparation height. If we don't raise the vertical dimension, we're going to have an issue with these teeth height. Goodacre, Schillenberg, we talk about 4 millimeters of axial height for retention of a crown. And also periodontally, do we do crown lengthening for the patient? Subgingival margins. This patient had several discussions with other practitioners, and they talked about endodontics, crown lengthening, post-cause, all sorts of major dentistry. I know in my own mouth, if I had teeth like this, I would want my teeth to be prepared. And I think neither of any of you would want to have your teeth prepared like that. So for this patient, we discussed using an additive approach where we add to teeth. But the first thing that we always start with is a facially generated treatment plan. So we look at the teeth, how they look in the patient's smile. So when the patient smiles, how do the teeth look in the face? So there are two things I look at. One is the repose, that is the lips at rest. Do we see any teeth on display? And we look at the vertical dimension. I know, Anthony, we just talked about vertical dimension. We don't have time to cover everything. But a lot of the factors with vertical dimension is about aesthetics. It's about phonetics, the f words, those sorts of concerns that we look at. So we look at that, we determine how long the teeth should be. And one of our first steps is to work out what sort of teeth display they should have. So the average 30-year-old at rest displays, for a female, 3.4 millimeters of tooth structure. And a male, about 1.9 millimeters. So we work out the length of the teeth. And we do the Emma test. And the Emma test is when they do Emma and they have their lips at rest. We can see in this picture, the patient has minimal display of teeth. When the patient smiles, their lip moves up 6 to 10 millimeters. So this here is one of the first key points in determining how we build up patients.
So to be clear, is the Emma test smile?
Emma test is the lips at rest, it's the repose. Then we can work out, do they show enough teeth structure? If they're not showing enough tooth, then we need to add maybe 1 or 2 millimeters. Then we also test the smile, because some patients have a very low smile. Some people have a very hypermobile lip, but they have a very gummy smile. So we need to determine not just the lips at rest, but also the whole smile as well. Okay. And then we talk about the vertical dimension. And in many of these patients, we need to raise the vertical dimension, because if we don't raise the vertical dimension, we are doing a conformative approach where we're preparing the teeth and keeping the same occlusion. In this patient with tooth wear, like all your cases, we need to open the vertical dimension. And we do that for aesthetics, we do that for restorative convenience, to have a thick enough restoration, and we may even change the occlusal relationships. One very important aspect is when you raise vertical dimension, oftentimes it changes the occlusal relationships. If a patient's a class 2 and you raise the vertical dimension, they're going to become even a larger class 2. So you have to be a little bit careful with how you manage vertical dimension. So in this patient, we talk about an additive adhesive approach. So do we do like a prepless approach or a less prep approach? So in this patient, I actually did a no prep approach. So I think Ian was very surprised when I talked to him about my philosophy. I don't believe in preparing these teeth. These teeth here, they're already short. There's already a lot of wear on these teeth. There's no need to prepare these teeth. So we did a no prep approach. So first of all, we do our typical diagnostic models. We do an articulation, and then we work out our plan. In this patient, we've opened the vertical dimension, and my plan was to carry out no preparation in direct ceramics for the maxillary teeth. In the mandible, I've built up the lower teeth, the mandibular anteriors, with direct resin. So I've used a combination approach. So let's see how we do this. So this case is 9 years old. Maybe these days I would be thinking about using a different type of stent. I know, Anthony, we just talked about the injectable approach, and I've done some cases now with some injectable flowables with Genial Universal Injectable, and I've been very excited by the results because it's just so much quicker to actually do the procedure, and it gives you, and the fact that the actual material strength is really, really high. So I'm very impressed by that. So in this case here, it was a putty key with a lingual shell, and we built up each tooth with direct resin. You can see here the 3 to 4 were built up. You can see here slowly the length of teeth that we added in composite, and we can see we get a nice result with direct resin. And I think it's a very conservative approach. We haven't done any preparation to the teeth, just a purely additive to those teeth. And then in the maxilla, they're the preps. There's no preparation whatsoever, apart from the teeth that have restorations in place. So you can see the 1, 7, 1, 6 have restorations. I've taken out the restorations, but the rest of the preparation is just basically taking an impression of the teeth.
How do you have a path of insertion?
Let's have a look at it, okay?
Before we move on, though, we've had a question about whether the patient had any TMJ symptoms, given that she has mandibular tori. Were you assessing for parafunction?
So she had a previous history of TMD on the left TMJ, but that had disappeared. So that had she didn't have that. That was many years previously. But I guess it's a good question because you really shouldn't be raising vertical dimension if the patient has some pre-existing temporary mandibular disorder. You need to manage that first prior to actually raising the vertical dimension or carrying out any restorative treatment.
How do you feel about a gift?
Yeah, I reckon that's
almost
a gift-worthy question. That one.
Congratulations, Anthony.
Question.
Yeah.
Great. Okay, carry on.
So, you were asking about path of insertion.
There it is.
You haven't seen these slides,
No.
but you can see here these teeth. There's no preparation carried out. You can see the dentine cupping. The only thing I've done is I've removed the restorations that were in place, and I've smoothed off some of the little chips that the patient had. But this path of insertion, you can see the actual teeth form. I call it what they call like a taco shell. Okay, they're like little tacos of ceramic. You can see how the path of insertion will fit onto those teeth. So no preparation. These little taco shell lithium disilicate restorations are then bonded onto the teeth. Okay.
And you obviously have to ensure that interproximally there was no incipient decay early on, wouldn't you?
Yeah, definitely.
Yep.
So he's finishing these supragingival to contact points.
They're finishing.
Sorry, yeah.
They're not even
Super contact points.
They're above the contact points.
Yeah, okay.
Not even involving the contact points.
Right.
Why prepare through those contact points?
Absolutely.
Okay. So here we then, as part of the diagnostic wax up, we do a trial smile. We do basically a test drive for the patient and make sure the patient's happy with how this looks. So you can see here, from the wax up, we transfer it into the patient's mouth. And you can see these are the bisacral resin temporaries. And you can see the patient smiling. Now I looked at that case, I looked at my nurse, I was patting myself on the back, saying how beautiful they look. and the patient hated them. Okay,
That happens.
and that happens.
It always
because
happens.
Yeah.
It's a big shock to them.
It's
It
a very big
always
shock to them.
is.
So you need to actually warn the patient that it's going to be a big change for
Yeah.
the patient. So this patient, I actually showed them. I was so disappointed because I was expecting big hugs and kisses. Nothing.
Look at you,
I was.
Chris.
The patient wasn't happy with.
How did you
with
manage it? Did you send her home and just convince her to give it a go?
Exactly. So I said to her, you need to give it some time for a few days. And I always pre-warn patients that it will be such a major change for you. We are reversing 20 years of wear in 3 or 4 hours. So
So how do you pick a shade for that? I mean, the Bisacral has got a limited range of shades. How do you go with that shading?
So these shades, I have a selection of different shades that I actually transfer into the patient's mouth. So this was probably a B1 shade, and I asked the patient, do you want to have, what color you like, A1, B1, and I actually show the patient, transfer it to the patient's mouth, give them the test drive. So if they're happy, then I'll go with that shade. If they're not happy, then we can change the shade still. Okay.
We've had a question as well. At which stage do you check phonetics?
So phonetics is here. So at this stage, at the provisional stage, you need to check phonetics. So we check the 55, 66. 55 is the length of the teeth. So if the teeth are too long, the patient will always feel like they're always touching their lower lip. They have a very how can I say, it's not a very clear F sound, okay? And then the S words, 66. When you say 66, patient's teeth just about touch. So if you've opened the vertical dimension too much, the patient will have trouble pronouncing 66, okay? I'm not sure with you, Ian.
Well, I guess, Chris, you would already know that if she's not happy with them, you would have tested the phonetics already because she would have told you what she really thought about them already by then.
And it's also difficult because I think people adapt to that. I mean, I'll often open the vertical dimension and they feel like they're tripping over their teeth. They'll come back within a couple of weeks and their speech is fine. So it's a tough one. But I think what you're saying is a good starting point.
But I think the key there for both your answers is that there's a period of testing. Yeah. That patient has to test their occlusion, their phonetics. You need to make sure you're happy with that, the patient's happy, before you go and start making the final restorations. They need to have a reversible material first so that you can check everything.
Yeah, okay. I think that's the difference between ceramic and composite. I mean, I'll put mine on. The worst possible thing is I can add to it, take it away, adjust it. And that's why I don't like to jump into ceramics until I've already done a composite thing. I think it's just a different way of doing it.
And that's where the transition, you can transition from composite to ceramics down the track because sometimes patients need to trial this out as well. They're not going to spend that much money on you on the first visit. They're going to say, look, let's start slowly first.
Absolutely.
And instead of trying to, just give them one option scenario, give them some different options that they can slowly progress into.
Well, that's great. You're changing my mind about prosthodontists, Chris. It's great.
Well, before we move on, if you've just joined us, you can contribute your comments and questions via the Henry Schein Facebook page or by taking out your smartphone, opening the browser on your smartphone and going to Schein.tv. And this evening, as you know, our experts are awarding thank you gifts to their favourite questions. If you're watching us on Facebook Live via a Facebook page that isn't the Henry Schein Facebook page, you'll need to switch to the Henry Schein Facebook page to submit your questions.
Yeah, so let's go back to the case. So this patient wasn't happy with the teeth. She went home. The kid said, you got horsey teeth. And then she came back. I actually shortened the teeth. But after a few more weeks of trialing, she said to me, please have them the same length as I originally gave her. So it's quite interesting. The patients have to have that period of adaptation. So
did you then do a add more and make sure she's happy with it before moving on? As in more,
I actually didn't. I actually just went straight to the finish. Okay. But it was about, I think we reduced it maybe another millimetre and a half. Okay, so not too much. So here are the restorations. You can see them on the model. I've taken one of the lithium disilicate off the dies, but nothing has been prepared on these teeth. You can see how they fit on. And they are sort of more like knife edge margins. So you can see how they adapt onto the palatal as well.
Is that the same as an infinity margin? I keep hearing about this infinity margin.
Yeah, so it's like an infinity margin. I mean, I'm going to cover it right now.
Oh, great, thanks.
So often people talk about this verti-prep. I know, Anthony, you're like this verti-prep. In this case, it was no prep. So it's really like a knife edge margin or a feather edge or a shoulderless. And we know that this is very useful in those cases with periodontally involved teeth, really long teeth. To do a proper margin, it's such a biological invasion to the tooth to actually prepare like that. But doing these sort of knife edge preparations, maximizes the tooth preservation. It improves the field of the restoration, and there's actually been some studies to show you have a higher mean failure load to fracture by having these restorations. So this case was no preparation. And you talk about an infinity margin. So some of you say, oh, these knife edge margins, it's very, very fine. Aren't they going to chip or fracture? You can always have them a bit thicker. I think you should have them at least 0.3 millimeters. But once you bond them in, there's no reason why you can't polish them and get them to an infinite margin like a prep, so it's really, really fine. Because it's the lamination effect. You know, once you bond something onto a structure, it becomes very, very strong. Okay, so
we've had a question on that front. What sort of cements and what shades of cements are you using here?
So this type of case would need a resin cement. So something like Linkforce would be very good here. It's a dual cure resin cement. In these sort of cases, I would like to use dual cure because they're quite thicker ceramics. I think anything more than 3 millimeters, you really want to be using a dual cure resin cement. Shade-wise, you can use clear. I tend to use like a more like a yellower cement to have a bit more warmth into cement. And that's what's just personal preference. I'm not sure what you like, Anthony. If you like.
You definitely wouldn't. In these cases, I definitely wouldn't use heated composite, as a lot of people would use, because of the pressure of that heated composite to get it to flow would just fracture those ceramics. So I would definitely use a resin cement. You know, depending on the case, how thick it is. But if they were thin enough, like let's say a bit thinner than what Chris said, I wouldn't mind using a light cured a flowable. I really love the genuine injectable. The fact that you've got a shade, I would use a high value shade, especially if it's an anterior, because I'd rather always be high value than lower value. So I could use that, especially for veneers. I've been using the GUI a lot.
It's certainly one of the times I unfortunately have to say glass ornaments are not suitable.
And Anthony, what are you using? Like, how are you preparing the lissi in this case, or the ceramic for if you are going to use genial flow?
We would always we would do the same with any sort of ceramics. We would if we would porcelain etch them, and then we would obviously wash it thoroughly. Then we would salinate them with like a G multi primer in some of these kits. And then we would just use the flowable straight on there. I wouldn't put a layer or bond on there. I don't think it's necessary. Some people do, but some
on the tooth.
On the tooth, I would put a bond, but I wouldn't put bond on the ceramics. Just with the newer generation of bonds are designed for dentine. I mean, it's not, unless you're using like a unifill where it's just pure bond only, then I would be fine with that. Yeah. Do you agree, Chris?
Yeah, I agree.
Yeah.
So let's go back to the case. So what about these feather edge preparations? You know, do they work? There are lots of studies to show that, you know, these restorations, even the feather edge, you can bond them into place. There's no biological or technical complications. This is 235 teeth, you know, one failure after 3 years. And the studies even with zirconia, there's Poggio and Monaco in 2013. They've shown that these feather edge margins do work on these cases. So this patient, we go to the removal of the temporaries. So you can see I'm removing the temporaries, and I prepare the teeth with aluminium oxide. This is 27 micron, blasted at 40 psi to clean the teeth. And you can see here, then our cementation is adhesive cementation, as we talked about. So because these are partial coverage, they're minimal retention. But the beauty about this case is that it's all enamel. You know, there's some dentine exposure on the incisal edges, but I have so much enamel to bond to. If I remove that by doing conventional crowns, I'm removing all that valuable enamel to bond to. You know, we know that bonding, adhesive bonding, it's very predictable to have enamel bonding. So if we can maximize enamel, that is the key.
Totally agree, Chris.
Yes. But I think also, what I also feel very strongly about is that when you remove enamel, you're also weakening the tooth.
Yep.
You're removing the structural rigidity of the tooth. So we can maximize enamel, you know, enamel preservation. I think that's really key to what we're doing. Okay. So here's the final result. You can see lithium disilicate on the maxilla and direct resin in the mandible. And for this patient, you know, it's just a life-changing transformation for this patient because she'd been suffering for a long time.
I'm desperately hoping that she was happy with that outcome.
She was
at the end.
She was very happy, and I still see her now. It's been like 9 years now, and she's still loving.
Did you
her
get your
teeth.
hugs and kisses?
I get lots of hugs and kisses from all my 80-year-olds.
I think you got elderly patients.
Now I know why he wants to be
You
involved
mentioned
with Miss
zirconia
Australia.
briefly, and there really is zirconia an option for anterior teeth. I would have thought the aesthetics isn't good enough.
So with the new zirconias, they have translucent zirconias. So these new translucent zirconias, they are weaker. This is the third generation in the last couple of years. So a lot of the zirconias have more cubic zirconia within them. It's not the typical tetragonal.
But it's still crystalline, so you can't etch it, you can't
etch
solinate it.
You can't
You've
etch it.
simply got to
Bonding is
bond it
an
with your
issue.
phosphate bonding.
Exactly.
Okay.
Exactly.
But when you're getting to that sort of rate, the amount of strength difference between a lithium disilicate and a monolithic zirconia, we're sort of very close. So
What are we doing agreeing on something here?
Well, it might be a chance for you to use glass ionomers on an anterior tooth.
you want to lead us down that path so we can cement the zirconia.
You have to remember that a lot of my older patients don't have high aesthetic demands. And I love Fuji bulk, one of the best materials around, although it is a very bright white opaque.
I don't use much GICs, but I love Fuji
But
bulk.
you take Fuji bulk and you cover that with Equia fork film, you've got something that's more wear resistant than conventional microfill composites.
Well, look, I agree with that, Ian.
I just have to keep pushing the glass.
Chris, you have to try some.
This ceramics and composites taking over way too much.
I'm interested to hear about your bollards. I mean, how are they holding up? I mean, GIC, traditionally, we think of it as a weaker material, not used for occlusal force.
Bollards have got two advantages. One, that they've got a smaller occlusal table, so there's a lot less force on them. I'm not creating a pyramid, you are creating a dome there. And with having less cuspal structure, you've got less twisting and torquing. I mean, I think adhesive dentistry fails more under a torsional load or a torquing force than it will straight occlusal load. So they're having only eccentric contact, to be honest. They don't have guidance planes. So it's really more about they don't tend to fail that much.
I think one of the older cases you're showing is that not only the older generation of the GIC had a bit more washing out effect, so what you're seeing could be a washout effect, but with this Fuji bulk, it's got the least amount of washout, or almost a negligible amount.
Yeah.
So.
No, I totally agree. It is the least soluble of all the conventional glass ionomers around. It's got incredible properties for what it is. It's just not great aesthetics. So not on the anterior teeth, sorry.
Chris, back to your case. We've had a question. What was your rationale for using ceramic on the upper anterior teeth and composites on the lower anterior teeth?
So,
aesthetics, I think.
Yeah,
Aesthetics.
yeah,
So
I mean,
she came in for aesthetics.
Aesthetics is aesthetics is one.
That's a gift.
Get a gift. Okay, so who was that? Sorry, we will.
But I guess, I mean, going back to the question, I'm not just using ceramics, as you can probably tell by now. I know I'm meant to defend ceramics and say how good ceramics are, and they are very good. And I think,
absolutely.
But there's a place for all these materials. Okay, maybe bollards. I've never tried these bollards, Ian, so I might have to start trying some of these bollards. I'd never heard the term before, and I said, "What's this bollards about?" But I might have to try that. But I guess I still use direct resin, and I think direct resin has a medium-term solution. But ceramics, if you want the material that has the best mechanical properties, then obviously ceramics is the one. It will give you the best aesthetics, best durability of the materials.
And this gets back to that age dependency we're talking about. I'm not going to do bollards really in young patients, and it's purely just to retain a fractured tooth or a root structure until it's going to be an implant or something. But older patients, it's certainly down that track. I mean, I've got a patient base, 70% of them are over 70, so I'm doing these a lot. Your practices might be completely different, so I think it depends on the application.
But I think what tonight shows is that we can diagnose and we look at these cases from a clinical scenario, but I think the key message is there's a lot of factors outside that determines what we use. Cost, patient affordability, patient wants, the age of the patient, whether they can go through and have Chris prep all that full arch cases. If they're at that age where in their 80s, they may not be able to sit through that comfortably. So they might choose the simple options. And I think that as dentists, we need to look at the holistic approach from what the patient really needs and wants and what they can be capable of managing in the chair, I guess, when we're deciding what sort of scenario that we choose for them.
Well, Chris, still on your case, a question, how have you attached or bonded the temporary try-in?
So I used a spot etch technique. So I've put a dot of etch in the mid-labial region, and I've basically placed the temporary material, the bisacral resin, into a template and fit it on top. So that's the way I typically do these sorts of cases, because this was a no preparation. There's no retention, so I have to give some sort of adhesion. So spot etch, and then apply my bonding agent. So in this sort of cases, we wouldn't use a self-etching bond. Otherwise, you'll find that it will stick onto the teeth. So we need to use like an enamel bond, an unfilled bond. Okay, something like that would be suitable.
Okay, we do have other questions, but is there any more to show us on this patient? I don't want to cut you short.
I think that's it.
Okay, so questions have been coming through for you, Anthony, in terms of it's all well and good for bonding to enamel, but if you're dealing with lots of dentine, how are you approaching that?
Look, I mean, if we're bonding to a lot of dentine, then this is one of the things we need to treatment plan and think about whether composites is suitable. Because when we all know that dentine won't bond as well, I mean, we can always do little things like micro etch. We can micro etch the teeth to increase it. We can obviously using new generation, they bond quite well. But inevitably, we need to decide whether the bonding to pure dentine is going to be enough. And in those cases, sometimes you might need to create a bit more mechanical retention. You might need to prepare an infinity bevel in there just to grip onto the tooth a little bit better. We're going to actually finish up with a case where it actually shows us exactly what we would do. If I can just go back to it, sorry, this case here. So if we finish up and talk about Graham, this is a perfect case to answer this question of what we would do, because this poses a scenario that as a general practitioner in private practice and in the public practice, that you would see this in a regular day-to-day sort of routine scenario. This is Graham, and Graham presented to me with teeth like this. He is currently 89 years of age. He's very medically fit and healthy. He presented complaining of pain on the lower right to the point where the erosion on the teeth were causing him to have irreversible pulpitis. So we know there's a problem there. It's not that something we can leave. And he's had 2 root canals because of this. The 4-4 was already root canal treated. The 4-5 needed root canal therapy. And the x-rays were showing that the pulps were almost to the point where they were going to be exposed again. And you can see that on the lower left on that photo there. In their cases where you've got minimal enamel, you've got very sclerotic dentine. You know, what would you do in these cases? Sorry? Yeah, financially the patient can afford everything. Is glass on going to stand up to the test of time?
Yeah, not in the long term. You're going to get good adhesion with this, but considering what you've got a shortened dental arch here. There's going to be quite a bit of load on this, so functionally it may not. You're right.
Look, I think if we're bonding composites, we just need to realize that it probably will work, but it just won't last as long. You have to inform the patients that there's potentially you're going to get some delamination and debonding, and this is going to be the case if you're bonding ceramics, unless you're creating mechanical retention in these. Chris, what would you say?
So, I mean, if you look at the literature supports in these sorts of cases, you need to roughen the dentine. Yeah. So you use either a burr of some sort, or you'd use, in my case, I use aluminium oxide, blasted.
Micro-etching.
So you need to actually roughen the dentine. There's some literature supporting the use of even etching on the dentine, and these sorts of really sclerotic dentine to roughen the.
And what's the point of that? You're going to just roughen it.
And roughen it. You're going to roughen it.
So it's not going to create a better resin penetration or hybrid layer.
You're just roughening it.
So it's purely mechanical retention.
Mechanical, yeah.
Are we worried about MMP activation in that case from sclerotic dentine?
Well, I don't think there's as much MMP activation in these sort of cases, but these sort of cases, I would even think about using mechanical retention. And that means we cannot just bond to these teeth. I'm not sure what your treatment plan was going to be, Anthony, if it was going to be direct resin, but if it was direct resin, I'd be creating some form of mechanical lock, whether it's some like a groove or some slots or whatever you need to help with that retention.
Yeah. But I would also, in these cases where you see the enamel is, I would make sure that I have composite in there. There was some enamel on the palatal surface. I would probably wrap my composite a little bit more into the lingual areas so that I have enamel to bond to. So using these out of the box technique, if composite was the modality of choice, then that's these things we'll do. I mean, at the end of the day, if you can't bond well to it, then we need to think of different options. I mean, and in this case scenario, the treatment hasn't been carried out, or there is some treatment carried out, but initially, Ian, we discussed this case, and we actually thought that, if he was in a position where he could sit through the chair, we would probably consider, he's got a short dental arch, we would probably consider some sort of full coverage restorations on the premolars, and maybe just composites on the upper and lower 3-3.
I think at some point in time there is this issue of stabilising what you've got.
Yeah.
And again, this is a patient that's got to 89.
Yeah.
They're pretty good teeth for an 89-year-old, to be honest.
But he's probably going to get to
If he's going to
easy
get to
100.
100,
Yeah.
you know, you've got 10 years of ceramic restoration is
That's
a good
right.
option. And I
And-
certainly would agree with it in that case.
And
I
is, if any kind of composite going to last that 10 years in that sort of
I
scenario?
don't think a direct restoration is going to last in this case.
And the worst case scenario is that when he gets to his 95, he's not capable of coming to the practice for repair and things like that. We've put him to where he's then starts to get these periapical lesions because the composite's popped off. So, you know, we need to consider long-term what we're putting our patients through. And look, at the end of the day, I gave him all these options, and you know what he decided he wanted to do? He wanted Bollards.
Bollards.
So at the end, we actually did Bollards. Ian, I hope you'll be happy. You're
I was
smiling
very
now.
happy now. Yeah,
We
that's
did
right.
Bollards for these teeth because he said, look, I just want the most simple, most conservative, and I don't think I could handle in the chair with all that time to do these crown preparations on them.
We have to wind up because we're running out of time, but just before we do that, a question that has been coming up from time to time is it really possible, we've been talking a bit about repairing composites tonight, is it really possible to get a good bond between old composite and new composite?
Yeah, I absolutely think there is. There's quite a couple of good articles written on this, and even in our Australian Dental Association news bulletin, and we've written a little piece on this. Really, think about it as just mechanical locking. You roughen it up, you can get some gross mechanical retention, but simply by air blasting, sand blasting, roughening it with a rough diamond burr, you want to make it as rough as possible. It's not going to be chemical adhesion, it's going to be micromechanical. You bond that, you put some flowable on, you then put your composite over the top, you get a really good adhesion.
Are you bothering with silane here?
Like you can, but you've got to do something like one of those systems that blast the surface with. I think silane priming works to a certain degree, but there's not much available glass in a composite. And realistically, unless you're going to fire particles, but you've got silane on
Some people use cojet, and cojet's a
well, that's
material.
basically
it's
the
like it embeds silica into the actual composite. So it's got a silica-coated aluminium oxide. So as you blast it, it actually embeds a bit of silica into it.
Well,
Yes,
the aluminium
I'm
oxide
not sure if
bounces
you've
off and
used it.
leaves
I've
you-
used it, and it flies
It's
everywhere.
messy.
It does
It's
messy,
messy.
you know. I think that's
Architects
definitely
look at the
deserving
land
of a gift, though.
Yeah, that's
Okay.
a great
Yeah,
question.
that's a definitely.
Thank you for your
Well,
question,
yeah.
Linda. So, all right, well, I'm not surprised we've run out of time and there's still an awful lot to talk about. But thank you, Professor Ian Meyers, Dr. Anthony Mack, and Dr. Chris Ho for spending time with us this evening.
Well,
That's a pleasure.
the science is over. Now it's time for some sake, I think.
Oh, I
Sounds good to
definitely
me.
think so. Yeah, that'll make
I
the
wonder
discussion
when the
flow.
sake. When was the sake?
There's a sake right
Good.
here now.
And thank you for tuning in. If our expert selected one of your questions or comments as their favourites, Henry Schein will get in contact with you via email or Facebook to arrange sending you your thank you gift. You can claim your CPD certificate by clicking the CPD button on the ScheinTV page on the Henry Schein Hallis website. Thanks again, and we'll see you soon on ScheinTV.
There you go. Here's a cheers to you all.
Cheers.
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 Kampai.
Kampai. Cheers.